The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Calling all pediatricians, family physicians, and advanced practice providers, the 47th Annual Common Problems in Pediatrics Conference is coming June 3rd and 4th, 2025. The best part, 100% virtual. Get the latest updates in pediatric care, hear from top experts, and earn CME and MOC2, all from anywhere in the world. Whether you're looking to sharpen your skills or expand your professional network, this is the event you don't want to miss. Register now at aaputah.org events. Welcome back to the Virtual Curbside. This is your host, Paul Wirkus, here again this month with our guest, Tara DuPont. Welcome back, Tara.
Thanks for having me.
This has been some interesting stuff. We inherit babies from the NICU, and I don't think that I think systematically about this often enough. And this has just been fascinating. So thanks so much for enlightening me, at least. You want to mention your disclosure again?
Yes, I will. I was the site PI for a study funded by Pfizer. The study ended about 18 months ago, but I'm still required to report it.
All right. So this week, if you'll be kind enough, I want to talk about some general considerations in post-NICU care. And it's interesting because, being in a newborn follow-up setting, these are things that you think about all the time. It's interesting because babies eventually graduate from the NICU. And unless you guys want to set up a boarding school, what happens then is they come and they join a family and they sort of get mainstreamed in a way, and they become part of the population that I take care of. And it becomes then a hybrid, both of trying to make sure that we're dealing with their particular needs, but also assisting this family in joining them into the family.
Yes.
So for one thing, shout out to general pediatricians, because one of the great advantages we have is that these are usually families that we know. And frequently, if this is not a first child, this is a family that we know, that we've known for a long time, and that we have the advantage of seeing each child as being part of a family. That said, this child often comes with a lot of challenges in the first several months, especially. First of all, what sorts of things should we be especially tuned into at the time of discharge? What should we be paying attention to in terms of follow-up issues and whatnot?
Yeah, I would say just kind of glancing at those diagnoses on your discharge summary. So, were there any major surgeries? Something I don't always think we counsel families too well on, or if there was any type of abdominal surgery or any necrotizing enterocolitis, there's always kind of a risk for strictures later on in life. So, just kind of having that at your forefront that this baby might need a little different care. And then kind of jumping to development a little bit more, I think really helping families feel empowered with taking care of their baby.
Yeah.
If it's a baby that has had a long NICU stay with a lot of medical complications, a lot of times those families know their baby better than any nurse, any doctor, and I would say just make sure that they know that it's a two-way conversation and meet their needs that way.
One of the things I know that a clinic like yours deals with, a newborn follow-up clinic, is getting, so you mentioned knowing the discharge diagnoses, but there's all of the stuff that has been coming to the bedside. Now they have to transport things like therapies and specialty follow-ups and all those sorts of things. Is there an easy way to keep track of all that?
In Utah, I think we're lucky in that when we do have babies discharged with multiple subspecialists, if we have more than 3 subspecialists, they qualify for comp care and a coordinated schedule. So we can get someone kind of monitoring to try to coordinate all of their appointments. We have some kids that are discharged with up to 9 different providers, and I just am so impressed with how families navigate that system.
Absolutely.
Yeah.
How about things that need ongoing care, like so like retinopathy of prematurity?
Yeah, I think this is something that actually gets missed a lot of times in our discharge summaries. Even if a baby does not have retinopathy of prematurity, preterm babies are still at a much higher risk for refractory errors, and that can lead to, strabismus and problems with vision later on. So all of those kids should be seen by an ophthalmologist around 6 months corrected age. Right? Just for routine eye healthcare maintenance. I think that's very important. Now, especially if there's a diagnosis of ROP or there was treatment for ROP, then they really need to follow up. But that one is critical.
And I think for the other kids, it's very easy for that to fall through the cracks.
It's so easy. I can't tell you how many times I talk to families in follow-up clinic and ask them when they saw the ophthalmologist, and they're like, "Then in the NICU, and they said we were fine." I'm like, "No, we're gonna go see I'm gonna refer you to ophthalmology."
Tracking neurodevelopmental concerns. I mean, obviously, we need to be paying attention. And as you alluded to a couple of weeks ago, that there's some correction based on corrected age. How much more sensitive should we be?
I think just still your general screening tests are whatever your clinic typically uses. One piece of advice is oftentimes you guys have busy clinics, like
Real.
a ton of kids. And so your MAs and nurses are saying it's a 9-month well child check, but the baby was born 3 months early. So it is probably important to give that family 6 months developmental information as opposed to 9-month developmental information. And then, at least in most of our computer systems, you do have to specifically check a box to get it to correct for gestational age. I think both iCentra and Epic do that in the hospital systems, but general pediatrician software, I'm sure, varies by practice. But you do
Right.
often have to check a specific box to get it to correct for gestational age.
And sometimes the specific box is just remembering to check in your brain. This 9-month old is a 6-month old.
Right. There are times where in follow-up clinic, a family will say, well, my pediatrician was worried because she wasn't walking. And I was like, she's 9 months old. I was like, your pediatrician did a great job. They noticed it. We just need to remember to correct for it. And that's where you get to advocate for your baby.
Right, right, right. So you've talked about a gestation for milestone. What are the things that would be the greatest risk factors for neurodevelopmental delay? What things do we see? What things should I highlight as I'm scanning the discharge summary?
Yeah. Unfortunately, a normal, air quote, normal head ultrasound, it can be a little reassuring, but many kids with a normal head ultrasound still go on to develop developmental problems. Remembering that the frontal lobe is one of the last parts of the brain to develop, it's often the most affected. So we are seeing increased incidence of frontal lobe related problems in babies, such as autism, such as ADHD. So those things might pique your interest a little bit more. Obviously, if you saw an MRI or a head ultrasound with a head bleed or a specific deficit, most of those babies are going to follow up with neurology clinic in addition to neonatal follow-up clinic, and they'll be able to track their development. But if you were to see something like that, I would be a bit more critical on your neurological exam and just seeing, is there clonus in this baby that's 1 year old and probably shouldn't have clonus at this age? Am I seeing that the left arm just seems to be a little bit more tight than the right arm? In which case, you can refer those babies to UDAC in Utah. And UDAC has 3 different components to it. So it's not just the neonatal follow-up program, but we also have a neuromuscular program that's really good at seeing kids that don't quite qualify by gestational age into our follow-up program, but have some type of problems that would warrant further monitoring.
What evidence do we have that early intervention helps?
That's a loaded question. Studies that use a rigid follow-up program show benefit. But when we look at it globally, I think there's a lot of different early intervention out there. Some is good, some is less good. So, early intervention, there's a variety of different types. Studies have shown that with a rigid early intervention type system, they do show benefit. When we look at it globally, it doesn't quite reach statistical significance. Anecdotally, I do see improvement, and that became evident to me during COVID pandemic, where a lot of our families were not routinely coming to neonatal follow-up clinic, but then they happened to be enrolled in a research study and would come back only for their 2-year visit. And I was surprised at how many kids I saw who were not getting early intervention services at 2 years of age, who did have typically mild cerebral palsy, where they had kind of were walking with a wide-based gait and a little bit uncoordinated with variable tone in their extremities. So while I can't prove it, I do believe that early intervention helps significantly.
It does seem to me too, there's a very great advantage in having what I think is a little bit more attentive collaboration with someone that as a parent is trying to do the right thing for their child, having someone who formalizes that to some extent, I think enables parents to do more.
Agree. Agree. We're part of some studies that are looking at specific early intervention programs specifically for cerebral palsy. And although I'm not completely involved in the studies, I do see the kids through clinic, and I have been thoroughly impressed with some of the massive gains that kids have made through these programs.
Let me just throw a couple of issues about supporting families through this process. How do you help people understand medical complexity without just completely overwhelming them, making them feel like they should have gone to medical school?
I think a lot of the families do feel that way at
Yeah.
distraction.
Yeah.
It's actually one of the parts I like a lot about follow-up clinic is I was with a lot of these kids in the NICU. I may have been someone who had to have a hard conversation with a family where we weren't sure a baby was going to make it, or we had to make a decision about whether or not we were going to go to the operating room, or we had to decide if we were going to try another course of a medication that had some risk associated with it. These families are traumatized. I think we're beginning to recognize how much they're traumatized, but I still don't feel that we're treating that adequately. When we look at long-term neurodevelopmental outcomes, it's the family that plays the biggest role. I sometimes laugh at some of our studies that we're doing. I did one on delayed cord clamping. So we think that 30 seconds of delayed cord clamping is going to overcome 6 years of parental interventions. There's no way, but parents are everything. And so I think that we need to have better resources for these families to help them deal with the trauma that they've experienced through the NICU, because that's going to help them raise a healthy child. I'm not sure that was the answer you were looking
Oh, that's very helpful. There's another thing, that we've talked for a long time about the issue of the vulnerable child and the sort of outgrowth of the combination of, anxiety. And I think we can appropriately call it PTSD of dealing with a very sick infant. I remember once, seeing a child in clinic, about 6'4" and, big, strong kid. And his mom said, but you don't understand. He was a teeny little preemie. He needs, and it would, no, he's a great big man now. And he seemed to have gotten through that very well.
Right? I don't know the answer to it, and I wish there was more literature on this. This is a field that I absolutely think deserves more study. We don't have enough social workers in our NICU. I think that would be a fantastic place to start, is just helping our captive audience in the NICU when families are there, help them recognize that this is hard. Our social workers are great, what we have, but they're tremendously overworked and can't meet all of their family's needs to the degree that they can. The vulnerable child syndrome is real, and my advocacy would be to seek therapy for it, but I just don't know the resources to do that, because I think they are to a large degree lacking.
And I guess the companion issue is walking people through the process of, being full of hope, and then finding that as a child's losing milestones, that maybe the child does have more deficits than we may have anticipated, or maybe even just that the deficits become more real because infants are very similar, but as a child is supposed to develop more, it's more difficult as they begin to lose milestones.
Yeah. In clinic, we see that, like, when we're making a diagnosis of cerebral palsy, it does seem like more often than not, the family expects it. And sometimes they kind of feel relieved to have a name for what they're seeing. There's still tears involved.
Sure.
And we're part of the early detection of cerebral palsy program. And so we do have a 1-month follow-up visit after a diagnosis of cerebral palsy, and where we come back and ask and try and answer their questions. It's usually a telehealth visit, but it's great. They can express concerns. Some families don't like the diagnosis, and we're like, I don't agree with you. And we're like, okay, well, wait, tell me when you're ready. Autism, similar. It's still your same beautiful child. We just put a name to it. And those can be some challenging conversations. When we do our prenatal counseling with families, I think it's impossible to convey this roller coaster that they're about to get onto, right? We talk about the big things, like we talk about ROP, we talk about, all of our 3-letter acronyms, PDAs, necrotizing enterocolitis, your baby's going to need to be intubated, blah, blah, blah. But I think ultimately what matters is my kid going to have friends? Are they going to contribute to family? Are they going to grow into an adult that can sustain themselves, or at least, do what they need to do? And I don't think we know that. Our outcomes are so physician centric, right? So we call it a good diagnosis if you don't have IVH, if you don't have BPD. I think what families care about is, my kid going to be on the soccer team? Maybe not, top, athlete, but are they going to be able to have friends?
And if not, how do they fit in our family?
Exactly.
What is the shape of our family with this child? Because I think in the vast majority of cases, people love and set aside all their needs for their children. And I think they just want to know, how does this child fit in my family?
I agree. I wish that our outcome measures looked at that a little bit more. We do actually know, though, that preterm babies in young adulthood have less risk-taking behaviors than kids that were not born preterm.
That's the silver lining.
Right? Right? Although also interesting, they're less likely to get married. Yeah. So they seem to be a little slower with relationships. And maybe that is related to this vulnerable child syndrome, this wanting to be, protected, and knowing that, in life we all make mistakes, right? And that's important for developing communication with relationships and everything else.
Humanity is staggeringly complex, isn't it?
It isn't it?
That's where all the richness in life lies. But Tara, thank you so much for your time this month. This has really, truly been fascinating. For one thing, I hope you're willing to come back in a week and answer questions, because I know there will be a lot of questions. I'd love to have you back sometime. We should talk about other stuff. It's very, very interesting. Thanks to all of you for listening over the last couple of weeks. And make sure and recommend this to your friends and family, and like and subscribe, because I'm very insecure and like to be liked. Thank you to Elisa Stoddard for making this sound like a podcast. And thanks, Janice, for listening. We'll talk to everyone next week.
Thanks for joining us. We look forward to getting together again next time. The virtual curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way, and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Production design and editing thanks to Phil Wirkus, who also composed the theme music. See you next time.